demonstrating strong leadership, including good clinical practice and ethics in the conduct of clinical trials. Professor Okoye is past observer of the Board of Union of International Cancer Control and chairperson of Nigeria Clinical Trials CWG Technical Working Group. Professor Okoye is as well convener of African Clinical Trial Summit and African Clinical Trial Consortium, ACTC. She's also a fellowship pastor, shepherd, ministry. She has been provost, and Professor Okoye is happily married with children and grandchildren. I have the very humble privilege of bringing on board, introducing Emeritus Professor Ifeoma Okoye to give the first presentation. Professor Okoye, ma. Hello? Hello? Hello, can I be heard? Hello?
Yes, we can hear you.
Thank you.
I can hear you.
I'm not sure. Is she on call?
I'm trying to reach her. So let's
Okay,
give her some few minutes in the next 1-2 minutes. Or we move on to the next, depending when I'm reaching her.
Okay, maybe do we move on to the next?
Yes, let's move on with Dr.
Okay, so
is on the phone.
while we wait for Professor Okoye, we'll move on to the second presentation while we await our call. The second presentation is on the roles of NGOs and CSO in cancer advocacy. And this will be presented by Dr. Adamu Al-Hassan Human, who is the president and the CEO of Nigerian Cancer Society. First, Dr. Adamu Al-Hassan, the floor is yours, sir. Is he also there?
Hello, good morning.
Good morning, sir. Good morning, sir. Dr.
Okay.
Yes, sir.
Good morning. Okay. Okay, you couldn't get Professor Okoye. Probably she's having issues with her network. So I think we are good to go. If I can have, I shared that is acting. No, but I'm trying to set up with the computer. So if you can share my slides from that end so that I can talk to it. Hello?
Hello, sir. Yes.
Yes, do you have my slides?
It's being put up, sir, I'm sure.
Sorry?
Doctor.
Yes. Do you have? I sent it to the Tofik earlier. Hello.
I think the IT person is trying to set it up.
Okay. Ina na ce kamun abincin nawa da kujera da wannan. Where is Iman? Very good, very good. I think it's up now because I'm also trying to
put it up. Okay, sir.
Yeah, yes, yes. So thank you very much. My name is Dr. Adamu Al-Hassan Umar, the president of the Nigerian Cancer Society. First, I want to appreciate this foundation for the consistency of purpose in creating awareness and of course adding to the body of knowledge that exists for cancer research and control. I truly appreciate the tenacity of the team, and of course, can you make it what, PowerPoint or something? Okay, it's all right. The tenacity of the team and in bringing experts, to talk around cancer. And it is our collective responsibility to ensure that we maintain and sustain the momentum for early detection, for prevention, and of course for prompt treatment, and of course survivorship for cancer. So I'm glad to be here today to talk around the role civil society organizations and non-governmental organizations can play in cancer advocacy in the country. Can we go to the next slide? So we will be looking at, we'll introduce NGOs, CSOs. Of course, we are all within the CSO space, so there is no need for introduction. And then we talk about cancer advocacy. Then we talk about the various roles we can play in strengthening cancer advocacy in Nigeria. And then we talk about the policies to drive change, to drive cancer advocacy. And then we talk about the progress we are making towards universal health coverage and, of course, cancer care by extension. Then we conclude. Yes, go to the next slide, please. So by way of introduction, non-governmental organizations and civil society organizations are very vital in health promotion and in health advocacy, particularly as it relates to advocacy for cancer and improved health outcomes. Now, what is cancer advocacy? Cancer advocacy is, of course, about what we are doing now. It's about raising awareness. Yes, it's about raising awareness, about influencing public health policies, and ensuring access to treatment. The focus is on how non-governmental organizations and civil society organizations contribute to cancer awareness, to drive policy change, and of course, to support patients, cancer survivors. So in essence, non-governmental organizations that includes the community-based organizations, faith-based organizations, and all advocates that can be categorized under individual advocates are very vital, towards improving health policies, towards improving health outcomes. Can we go to the next slide, please? So, what are we talking? Like I said, raising awareness is one very critical component of what civil society organizations can do. campaigns for early detection, for prevention and treatment options. And informed mind, is a healthy mind. Because when you look at our societies, especially on this part of the country, most of the issues around cancer are due to ignorance, are due to lack of education. You come to my locality, for example, and see how people are categorizing all sorts of ailments as cancer. They will tell you that it's jeji. Don't go to the hospital. If you go to the hospital and they inject you, you will die. But ultimately, it is when this ailment has progressed and, of course, transformed into cancer, even if it is not cancer at the beginning, that eventually when the patient is taken to the hospital at a very late stage of the disease, and at that point, it's only palliative care that can be done, to salvage the situation. And ultimately, the patient dies. And they will say, we have said it before. So awareness is very important to educate the public on the risks associated with cancer, to talk about screening methods, and of course, lifestyle changes. Because lifestyle changes plays a very important role in modifying the risk that we have for cancer. And when you consider the fact that over 30% of most of these common cancers are highly preventable, with another 30% or more highly treatable when detected early, you discover that over 60% of most cancers are either preventable or treatable. So awareness creation is very key. Now we talk about policy advocacy. This is a significant role that non-governmental organizations can play in lobbying for government policies that prioritize cancer care, in advocating for increased healthcare funding and research. You remember the institution, the National Institute for Cancer Research and Treatment, that is about a year old now. There was no NICRAT in the past. And this bill that established NICRAT was signed into law since the year 2015. But implementation only happened about a year ago. Why? Because civil society organizations, non-governmental organizations pushed for that bill to become law. There is what we call the Cancer Health Fund now, the government intervention that assist indigent cancer patients that are suffering from breast, cervical, and prostate cancer, that is piloted in 6 hospitals across the country. The same fund is as a result of push by the private sector coming together with civil society organizations to push for an agenda for government to allocate a certain amount of money for indigent cancer patients. So policy is a very vital tool that non-governmental organizations are very critical, in pushing for change. I remember in the year 2022, during the commemoration of World Cancer Day, we made a passionate appeal to the Ministry of Health to add more cancers to the Cancer Health Fund, childhood cancers and hematological cancers. And of course, we advocated for more hospitals to be covered. And of course, the Minister of Health at that time, in his response, agreed to the fact that they will add childhood cancers and hematological cancers, and they will also add 1 hospital in each of the geopolitical zones. But in Nigeria, policy documents are very beautifully crafted, but implementation is usually where the problem is. So, but we keep pushing so that we can make it happen. Capacity building, training healthcare workers and volunteers. This is what we are doing here. From this particular webinar that we are having now, many will take up the mantle, especially first-timers that are attending this webinar will take up the mantle to go and become strong advocates because their capacity has been enhanced. So that is a role that civil society organizations can play, because they are the ones at the grassroots level. They are the ones that are interacting with the masses, and they are the ones that, if they have volunteers that are capable, they can easily be able to translate, the advocacy messages to the localities. Enhancing community outreach for rural and underserved populations. Yeah. Support for patients and survivors, very important. Providing psychological support, financial aid, and counseling. We have all seen how individual organizations are doing GoFundMe, crowdfunding to be able to support indigent cancer patients in their localities. And I always say, it is only when you are in the locality and you relate with the people of the locality that you know the peculiarities of the people in that locality. So whenever I see a certain organization taking up the mantle of trying to raise a certain amount for a particular patient, I always give them that support. I give them that, encouragement to maintain, because if we can succeed in identifying these core indigent cancer patients all over the place, and through our individual efforts are able to galvanize support for them, it will go a long way, because palliative care is one aspect of cancer care that has been grossly neglected. And, in Africa, generally, when we talk about end of life, people don't want to talk about death. People don't want to talk about death. But it is very important and critical, because the last 1 year, the last 5 years a person can have on earth, the quality of life matters a lot. So it is very important for civil society organizations to concentrate their energy on support for patients and survivors, and of course, support to caregivers. Creating patient groups to empower survivors to advocate for better care. They will say, if it is about us, it has to be from us. So when you have survivorship groups, when you have people that are in the middle of the situation, they are in a better position to tell. They say, he who wears the tight shoe is the one that tells where it pinches. So it's very important for civil society organizations to bring survivors together, to form survivorship group, so that they can talk to themselves, so that they can invite experts to talk to them. A lot of organizations are doing that, and that is very commendable. Monitoring and evaluation, assessing the implementation of government cancer programs. When we say M&E, we are talking about follow the money. There is an organization founded by a friend of mine, Hamza. Hamza is doing very well with follow the money. And we need to have similar concepts, for cancer. Following the money is all about ensuring accountability. It's all about budget tracking, to know where the money allocated by government is going to know whether this money is allocated and used appropriately. And gathering data, of course, to hold stakeholders accountable. Advocacy cannot be effective if you don't have the requisite data. So it's only when you have the data that you can be able to talk and convince policymakers in a scientific manner. Next slide, please. Okay. Now we are talking about policies to drive advocacy efforts in eliminating cancer. We have talked about general policy statements. Now, the National Cancer Control Plan, that is a roadmap to improve cancer care, screening, and treatment structure that encourages collaboration between the government, private sector, and the civil society organization. This is a document that all cancer stakeholders converged in Abuja and developed, and it is part of the 5-year NICRAT strategic plan. Everything cancer is in there, in that National Cancer Control Plan. And the expectation is that the implementation shall not be only by government, because there is a role for everybody, the private sector, the civil society organizations, the government, and everybody. So it is a very imperative for civil society organizations to have these documents, to know what the contents of these documents are, and to know where to fill in the gaps. We are talking about health insurance expansion policies. Not too long ago, the National Health Insurance Act was amended to make it the National Health Insurance Authority, making health insurance cover compulsory on all Nigerians. It is about extending health insurance coverage to ensure cancer treatment is affordable for all. Not too long ago, Nigerian Cancer Society was a party to the review of the essential medicines prices and professional fees by the National Health Insurance Authority because of the changing times. And gradually, we are moving towards ensuring that every Nigerian is covered under the National Health Insurance Authority, particularly as it relates to us cancer patients. And I have it also in good authority that the National Institute for Cancer Research and Treatment is working very closely with the National Health Insurance Authority through avenues to ensure that the Cancer Health Fund and the Cancer Access Program and other, cancer related concepts that are already in play, like the cost-sharing mechanism between National Health Insurance Authority and ROT, are consolidated and make to work effectively for the benefit of the teeming cancer patients in Nigeria. There is in the new law establishing the Health Insurance Authority, there is a particular fund that is supposed to cater for about 72 million Nigerians. It's called the Vulnerable Fund. That fund is supposed to be dedicated to have insurance cover for indigent cancer. For indigent patients, the elderly, the young, the people with disability and all that. So we hope civil society organizations will continue to push so that the authorities can do the needful. Cancer research funding policies, of course, advocacy for increased public and private investment in cancer research, is very important. It's not only government. Everybody has business in cancer. The Dangotes, the Femi Otedolas, the Boas out there. A lot of them are channeling their energy and resources towards interventions that has to do with cancer. Influential politicians that can bring about, access to cancer treatment centers. Very important and should be encouraged. Public-private partnership, of course, like I said, cancer is everybody's business, and the private sector has a significant role to play. If you notice, particularly in places like Lagos, Calabar, Port Harcourt, mostly in the South, the private cancer centers that are doing very well are out there, and they are privately owned. They have everything that you can expect to see in a cancer facility, and we will get there someday by the grace of God. I hope in the near future there will be a sophisticated cancer center in my village of Bayam in Jakusko local government area of Yobe State, so that cancer patients from my locality will not have to travel out of the state or out of the country to get attention. Can we go to the next slide, please? Okay. Progress towards universal health coverage. We have talked about universal health coverage because we cannot achieve the success we are talking about if there is no insurance cover for all Nigerians. And so universal health coverage is very important. It aims to provide access to essential healthcare without undue financial hardship. That is the target. Even though insurance cover is now compulsory on all Nigerians. But how many Nigerians are insured? When you look at it, you discover that only those within the working class, working with the federal government and those with state are insured. But the informal sector, the market women, the fishermen, the farmers are all neglected. They are not covered under any form of insurance. So this is the target for universal health coverage. Cancer care is central to achieving universal health coverage because ensuring prevention, curative, and palliative care for all is the panacea that will help us address the cancer burden in Nigeria. What is Nigeria's current status There is progress in expanding the National Health Insurance Scheme, like we talked about, that is now National Health Insurance Authority. However, there are still large gaps in cancer screening, diagnosis, and treatment, particularly in rural areas. We are happy the National Institute for Cancer Research and Treatment may have some plans in motion to establish cancer screening centers. And as advocates, we will monitor and keep our eyes on the goal for them to do the needful, provided they have factored it into their work plan and they have factored it into their budget. We should ensure that these cancer screening centers are established, not only established, are functional, and of course, people are getting access to them. What are the challenges? Inequitable access to healthcare resources, we know in Nigeria, with over 80% of out-of-pocket expenditure, with more than 50% of the population living below the poverty line, with over 60% of the population living in rural areas. Access to healthcare, particularly to cancer screening services, is a major problem that we have in Nigeria. Lack of specialized cancer centers, of course, and limited healthcare workforce. It's not just about building. You have to build, you have to equip, and you have to get the trained manpower to man these cancer health centers. There are some states that have erected buildings in the name of cancer health center, specialized cancer centers, but the equipments are not there. The human resources are not there. So we need to train, retrain, and we need to get the best of equipment so that we can be talking about, high impact, to the community. High out-of-pocket expenditure, I have mentioned this, not only for cancer, for health generally. What are the ongoing efforts? Partnerships with international organizations, the World Health Organization, Union for International Cancer Control, and other international bodies to bolster cancer care. Development of regional cancer centers and training programs for healthcare workers. This is what I said NICRAD is working towards. Next slide, please. I think I'm taking too much time. Let me quickly rush. How close are we to attaining UHC? No, next slide. Oh, no, wait. Okay, no, last slide, okay. So the progress, we said there is expansion of health insurance coverage and primary healthcare services, especially with the state health insurance authorities, increased awareness of cancer prevention and early diagnosis. This portrays the more reason why programs like this are very important. The challenges are still there. Future directions, insufficient infrastructure and comprehensive cancer, financial constraints, limiting access, okay? Future directions, strengthening of partnerships between non-governmental organizations. No man is an island. We all need to work together. We all need to come together to synergize, to collaborate, and partner in progress, for the betterment of the country. Government, private sector, everybody needs to align. And then, of course, when we think individually, we can make impact. We may be dreaming, all along. We all need to come together for us to create the necessary impact. Investing in cancer treatment centers, healthcare worker training, and accessible diagnostic tools. Emphasizing policy reform and accountability. I have mentioned all this before. Next slide. So, in conclusion, non-governmental organizations, and of course, by extension, all non-profit, community-based, faith-based organizations play a critical role in cancer advocacy by raising awareness, driving policy change, and supporting patients. Now, the policy efforts such as the National Cancer Control Plan and healthcare expansion are crucial for improving cancer care. Universal health coverage is attainable, but there is much work that needs to be done, especially in addressing inequalities in access to cancer care. And non-governmental organizations have a very significant role because, as the name implies, they are non-governmental. They are like the watchdog to the government. When you have a constructive argument backed by evidence, you can always push for change. And that is actually the role that we are supposed to be playing. Is there a last after the last slide. Okay, the call to action now. What we need to do to support cancer advocacy efforts. We all need to join hands, working, all of us working in the cancer advocacy space. I am happy with what is happening over the years, especially during my current tenure as president of the Nigerian Cancer Society. The goodwill has been enormous, and it's only when we are together that we are stronger. I was recently approached by a firm, by a consortium, that we were already in talks, for the Nigerian Cancer Society to coordinate a national screening program through civil society organizations, through NGOs, for one of the cancers. And that is only possible because they see that every organization is projecting the image of the Nigerian Cancer Society as the national umbrella. And that is what we need to do. If we truly wants to be valued, if we truly need outsiders to take us seriously, we don't go as individuals. We go as a group, we go as a unit, and we work in synergy to advocate for improved policies and more robust funding for cancer care. The same thing. There is this divide and conquer approach. If government knows that your heads are divided, they will not take you seriously. I remember when one of our organizations, End Cervical Cancer Nigeria Initiative, initiated a move for the National Cervical Cancer Control Plan to be reviewed because it expired and it was not reviewed. So that organization engineered a process, and we collected signatures of individuals and organizations, and we sent a letter. And before you know it, a committee was set up for the review of that National Cancer Control Plan. So it's only when we go as a unit, when we have our collective efforts and to address our concerns, that is why we get clarity and we get the support of government. So we all need to get involved to support cancer patients and their families, to help raise awareness in our communities. So I want to thank this organization very much for inviting me to talk. And I want to also pledge that I will be available for any physical activity or virtual activity, as the case may be, because I have seen the tenacity, I have seen the energy in the team, and I have seen the commitment of members that are sacrificing towards this objective, raising awareness, touching lives, and of course, making significant positive impact in the society. So thank you very much once again for your time, and I will be available for any questions that may arise. Thank you, and over.
Thank you very much, sir, Dr. Adamu Al-Hassan Huma. This is a very strong unifying speech from you, sir, emphasizing on teamwork, working together for elimination of cancer in our society, particularly in Nigeria. Very strong unifying speech with presentation. We thank you, sir. Dr. Adamu Al-Hassan Huma is the president, CEO, Nigeria Cancer Society. Professor Ifeoma Okoye is on the call. So we'll be having our presentation now. I'm coming.
If you give me sharing rights, then I'll see if I can share my slide.
I don't know if...
Can I try to share it myself so that I'll move it as I need?
Okay, ma.
First, okay. Thank you.
Thank you for coming, ma. You're welcome, ma.
Thank you. I was having network challenges. I'm sorry about.
We're happy to have you, ma. Professor of Professors, ma. You are welcome, ma. Professor Ifeoma Okoye is the first UNN professor of radiology, the first female professor of radiology in the whole of Southeast and South Nigeria when she became a professor. She has more than 80 peer-reviewed, 80 papers published in peer-reviewed journals to her credit, and she has authored and contributed to more than 7 books. Professor Ifeoma Okoye has more than 4 decades span of training of physicians and radiologists. She's a teacher of teachers, has mentored several physicians, and has touched life through several non-governmental organizations impacting life. And she has been thoroughly involved in scaling up capacities for clinical trials across Africa. Professor Okoye is also an Ashoka Fellowship awardee after demonstrating strong leadership in good clinical practice, ethics, and conduct of clinical trials in Africa. You are welcome, ma. You are welcome, ma.
Thank you very much. Okay, you're still hearing me. Are my slides showing very well?
Yes,
Hello?
ma.
Okay.
Yes.
I'm actually doing everything from my phone, but it's probably easier for me to control. Good afternoon, everybody. Good afternoon, Dr. Debo Yega. I hope you can as well. And our phenomenal NCS president and all others that are here, distinguished audience. I greet everybody and I apologize for coming in as it were late, but it's to look at research and how it's going to more or less contribute to overall better outcomes for patients in Nigeria. And I'd actually tried to twist the topic a bit so that we would all have the idea of how, what exactly we are trying to achieve through this presentation. And I therefore recharged it to read Challenges in the Control of Cancer in Nigeria, and how through research we as stakeholders can put our hands on the plow to combat these challenges. Through research, how can we combat the challenges in cancer control in Nigeria? So that's the question that is before us, and I've already been adequately introduced. And I look at that same question asked in a different way. Why the need for disruptive mechanisms in repositioning Nigeria's oncology systems for closing the care gap? And I think our phenomenal president of NCS has done a great job in outlining all the progress that has been made and the gaps that are still existing. So the come to the next one. There is a need for mass action. There's a need for mass action across the continuum of cancer control, awareness, diagnosis, screening, treatment. And a lot of times we stop there, but there's the huge elephant, research. We are tired of talking and have instigated different mass actions, such as has been already enunciated, across the continuum of care, covering awareness, diagnosis, screening, treatment, and bringing together organizations such as NCS has done that speak to each on these pillars in a structured and results-driven way. So even Federal Ministry of Health, NICRAT, supports this view considerably. You've seen the many ways in which they have shown support. And the country has placed premium on high-value-based approach to change the narrative. I quarrel with anybody who says we are still in the doldrums in cancer control, because we are truly mustering all our energies together to see what we can do to improve the narrative. We have leveraged on partnership with consortia of result-oriented local and international NGOs and multinationals. You can see some of them were listed during the presentation by the NCS president. So I want to just use breast cancer as a case study, just to introduce us into the armamentarium of some of the challenges and some of the things we are battling still, fundamental issues. So breast cancer has overtaken lung cancer as the world's most diagnosed cancer, according to statistics released by international agency, IAC. And a woman's chance of developing invasive breast cancer at some time in her life is approximately 1 in 8. And I'm giving you US figures, and then I'll give you Nigerian figures. So high-income country, low and middle-income country. So about 40,000 American women die from breast cancer each year. It's a huge problem. It's a public issue, a public health threat. So breast cancer death rates have declined significantly. Mark that, there's a decline, significant since the 1990s, especially for women younger than age 50. But what are we seeing? We're seeing more and more of young women in Nigerians coming down with breast cancer. And you're seeing people even under 20. There are currently more than 2.5 million breast cancer survivors in the USA. In the precise conference we had recently, a lot of radiologists, because their personal experience of seeing more and more young women with breast cancer. Now, there is more than 2.5 million breast cancer survivors in the country. The cancer survivors are about to have a monumental event in November. It's initiated by them and being put together by them and going to be run as they want to run it. So people with lived experience have come together as a big platform, and they are championing this conference in Lagos in November. Now, if you were to ask them how many total do they have, it would be less than 1,000, I'm sure. It probably will be less than 1,000. But we are talking about 2.5 million breast cancer alone survivors in the USA. Comparatively, UNTH records show that the prevalence of breast cancer is increasing. In Nigeria, breast cancer is the leading cause of cancer deaths, currently representing 23% of all cancer cases and approximately 18% of deaths. And 83 to 87% of them come in at late stages, increasing death rates by 70%. And 1 in every 25 women dies of breast cancer in Nigeria. Every 68 seconds, a woman dies from breast cancer and accounts for 1 out of every 3 cancers that are diagnosed. The 5-year breast cancer survival rate in Nigeria is less than 40%. This is compared to 86% in the USA. This fortified the narrative that breast cancer is a death sentence and continue to make it difficult for us to convince our populace otherwise. I'm sure funding constraints and all that have also been handled. So let's look at the structures and policies with impact on cancer research that we have in place. One of the most exciting outcomes of what has happened this year and 2 years ago is the advent of NICRAT, and then the Minister of State for Health and Social Welfare, Dr. Tunji Alausa, introducing a greater beacon of hope in the fight against cancer in Nigeria when he recently declared cancer a notifiable disease in Nigeria and unveiled the national guidelines for cancer registries in Nigeria. Now, a notifiable disease is a disease that, when diagnosed, it requires health providers, usually by law, to report to state or local public health officials. Declaring cancer a notifiable disease of public interest in Nigeria is a significant step forward in the fight against this devastating illness. In fact, Professor Adewole, the former minister, I heard him at one of the current gatherings we had online, actually congratulate the minister on this trust that he has put in place. Now, this move acknowledges the contagiousness, severity, and frequency of cancer, aligning with the Centers for Disease Control and Prevention's definition of notifiable diseases. Dr. Tunji Alausa's announcement and the unveiling of the national guidelines for cancer registries demonstrate the government's commitments to tackle cancer head-on, because it did the two at the same time. And it's a clear evidence of the immense work by advocacy groups who are under the leadership of the Nigerian Cancer Society and the National Institute for Cancer Research and Treatment. These impactful stakeholders have been instrumental in pushing for progress. Their tireless efforts, combined with the government's support, will definitely, undoubtedly, lead to better cancer prevention, diagnosis, treatment, research and development, and clinical trials in Nigeria. So, what are the key benefits of this declaration and strengthening of cancer registries in Nigeria? They include the following: improved data collection. Making cancer notifiable disease is a significant step forward in cancer research. By doing so, healthcare providers are required to report cancer cases to state or local public health officials, which leads to more accurate and comprehensive data collection, which, of course, we have been battling with global figures rather than having our own germane data. This is especially crucial in countries like Nigeria, currently in the process of strengthening its registries. With cancer as a notifiable disease, population-based cancer registries can provide valuable insights into cancer incidence, distribution, and survival rates. And this data will be essential for the following: identifying cancer hotspots and areas where targeted interventions are needed, so you apply funds exactly where they are needed, tracking cancer trends over time to evaluate the effectiveness of cancer control programs, informing cancer research and policy decisions. And these are so important because there is a rollout program right now that NICRAT has put in place. Cancer registries will thus provide valuable insights into the prevalence and distribution of cancer in Nigeria, enabling more targeted interventions. And we'll be quoting our own figures rather than figures that were adopted by extrapolation. Now, continuing on the key benefits, there is also enhanced cancer control programs. By making cancer a notifiable disease, governments can develop more effective cancer control programs. Even funders, even private funders will be ready to fund because government has taken a bold step. So, and there will be enhanced prevention and early detection, with healthcare providers becoming more vigilant in identifying and reporting cases and leading to earlier detection and treatment, and offer at the point of care. Increased funding for cancer research, screening and treatment, improved access to cancer care services, especially in underserved areas. Enhanced awareness and education campaigns to promote cancer prevention and early detection. This is still very fundamentally and it's a fundamental issue, but very, very, very imperative that we continue to pay attention to it in order to debug our tumors and downstage them and have survivors to survive in order to share their positive stories and change the negative narrative around the cancer ecosystem. So there's the real world impact. The National Cancer Control Program, NCCP, can better track cancer incidence and evaluate the effectiveness of its programs. Increased funding and support. This declaration may attract more resources. I'm telling you, when you now go to different corporate entities, they must have heard this news and they know there is an alert on this disease entity. So it will attract more resources and investment in cancer research, treatment, and awareness programs. Now, it will also help to inform next steps, such as ensuring the implementation of national guidelines. Effective implementation of the cancer registry guidelines, for instance, will be crucial in ensuring accurate data collection and reporting. Fostering collaboration and awareness. So it will also drive continued collaboration because the whole world heard that statement. And I believe that even in Onga, they must have emphasized it. So continued collaboration between government agencies, advocates, and global organizations, especially international research sponsors, such as NIH, EDCTP, WHO, IAEA, Global Pharma, and it will scale awareness and promote cancer prevention strategies as evidence drives and informs policy. So, just rounding up on the key benefits, this development is a beacon of hope in the fight against cancer in Nigeria. With sustained effort and commitment, we can look forward to better outcomes and a healthier future for all Nigerians with lived experience. Overall, making cancer a notifiable disease is a critical step towards improving cancer research, prevention, and treatment. By leveraging accurate data and enhancing cancer control programs, we can work towards reducing cancer's devastating impact. So now let's look at a very critical aspect of the research that we must pay attention to, and that is the area of oncology clinical trials. The volume at this moment is very low. I was at the UICC when I was observer to the UICC board, and we visited, some of the institutions we visited, and one radiologist was telling me that all she does is oncology clinical trials. That's all her job. All their patients, population, more than 80%, are engaged in the clinical trial process. If you go to England on referral, and you visit a doctor, after seeing you and doing all the tests, he will now give you a list of clinical trials that are going on in the area of the cancer you have come in with. So increasing the volume of oncology clinical trials can have a profound impact on cancer research, patient outcomes, and the broader cancer community. Thus, the following strategies are needed to increase volume of oncology clinical trials, and they include improved cancer research, increased funding for clinical trials, collaborative research models, industry, academia partnerships, that is industry partnering with academia like we have, Roche, for instance, partnering with the government to ensure that drug access is improved and CHI and all that. So streamline trial design and regulatory approvals, leveraging real-world data and AI in the trial design, and diversifying trial populations, inclusive of underrepresented groups. The strategy will also involve improving patient outcomes. This would involve access to innovative treatments and therapies for the patients, which they would not have otherwise been able to afford. Personalized medicine approaches will be available, enhance quality of life and survival rates, improve symptom management and palliative care, and increase patients' engagement and education. Recently, I was included in the iCare project for prostate cancer in Black men. And, there's a lot of effort working with the patient themselves, even in the area of research. So oncology clinical trials and unlocking the study participants recruitment in Africa, because it is this availability of participants that would be one of the carrots that we can use to attract pharmaceutical companies, because they're actually the ones who engage in drug trials. So oncology clinical trials change narratives for persons with lived experience, patient-centered care and advocacy. Storytelling and awareness campaigns can improve this, support networks and communities, inclusive trial design considering patient preferences. That is inclusion of patients in the whole process of even designing the protocol. Empowering patients as research partners. That's what iCare is doing for prostate cancer patients across the globe. So also improve continuum of cancer control and care through screening and early detection programs, standardized care pathways and guidelines, multidisciplinary care teams, which of course now we are doing MDTs in most of the oncology centers, survivorship and rehabilitation programs, and end-of-life care and palliative services. Very, very important. Of course, we started the Breaking Bad News issue and the patient support groups. And all these are all important and inclusive. And there is research. ACS is in, CHI is in, and there's research coming in to engage in these different areas in the continuum of care. Other strategies to increase oncology clinical trials include National Clinical Trials Network, forming a National Clinical Trial Network, community-based trial sites, academic industry partnership, adaptive trial designs, patient advocacy and awareness campaigns, regulatory harmonization. And I can tell you now that there is, AVRF has fostered a process over the past almost 10 years now of harmonizing clinical trial regulations across the continent and streamlined approvals, real-world data and analytics, artificial intelligence in trial matching and design, global collaborations and trial sharing, and education and training for researchers and clinicians. So you're developing the workforce and you're developing the infrastructure and the ethical frameworks as well. So we also need to engage the stakeholders. So we engage with stakeholders to achieve increase in oncology clinical trials, such stakeholders as researchers and clinicians, patients and advocates, industry partners, pharma, biotech, regulatory agencies, government funding agencies, healthcare systems and providers, research institutions and universities. So how do we engage the researchers and clinicians? You collaborate on study design, you provide education on the latest research methodologies, and you expand their skill. You foster open communication to address challenges and share best practices. You encourage peer-to-peer networking and knowledge sharing. And you support research grant applications and publications. I think it was a team of researchers recently did the challenge, the cancer challenge, and they got $21 million worth of grants to work on social determinants of cancer. We can engage as a collaborative to write grants and muster such funds to come in and be utilized within our country. So patients and advocates, you educate them on clinical trials, the benefits and the risks so that they don't have a guinea pig mentality. You involve patients in trial design and protocol development. You provide support and resources for trial participation. You foster patient-centered care and advocacy, and you encourage storytelling and awareness campaigns. And for industry partners, how do we engage them? We collaborate on trial sponsorships and funding. We have a proliferation of CROs. We encourage them to come into the sector. We align trial goals with business objectives. We share data and insights to inform trial design, and we develop public-private partnership and ensure compliance with regulatory requirements. So also regulatory agencies, I've already told you how there's harmonization across the continent. And of course, we have typically NAFDAC, and then for the ethical framework, the National Health Research Ethics Committee and the Health research ethics committees of the institution, IREC. So government funding agencies like TED Fund, EDCTP, global funders like EDCTP, NIH. You also have IAC and the others. So you need to, form groups, teams, collaboratives that can, sit down together, of course, led by NICRAT, to identify funding opportunities and grants, develop persuasive grant proposals, collaborate on research priorities and agendas. I tell you that 21 million that was gotten was boosted by about 3 or 4 very heavyweight institutions, including Johns Hopkins. So collaborative on research priorities and agendas ensure alignment with national health priorities and foster relationships with program officers. This is not the time to operate in silos. No wonder the NCS president was, stressing on collaboration and partnerships. Now, the healthcare systems and providers you need to engage with, you integrate the clinical trials into routine care, develop site-specific trial infrastructure. Do you know that the heaviest clinical trial in Britain actually goes on in childhood cancers? So ensure trial participation is seamless for patients, provide education and training for healthcare staff, and monitor trial progress and outcomes. These are very important. So finally, research institutions and universities collaborate on research initiatives, we develop academic industry partnerships, foster innovation and entrepreneurship, and provide research infrastructure and resources. And we have such a unit in the University of Nigeria, which I heard that is called the UNN Center of Excellence for Clinical Trials. And truly, we are advocating that we ensure that this happens in most of the places. So we are looking at engagement strategies, and we can see it. I don't think I need to start going through it so that we can go through some of the more important aspects that I want us to look at. And there is the African Clinical Trial Consortium, which is actually advocating for creation of these clinical trial units. The UNN Center of Excellence for Clinical Trial is actually a clinical trial unit. And this is what the UK did. They created clinical trial units and used it to leapfrog their clinical trial industry. The reason for that is that they are focused and specialized biomedical research units, which design, centrally coordinate, and analyze clinical trials and other studies. What it essentially does is it takes away the clinical trial process from the busy clinic and concentrates it on a workforce that have been trained to be GCP compliant. Next slide. So you can see that there's a lot of things that are, mitigating against higher volumes of clinical trials coming into our sub-regions. Lack of confidence in the clinical trial quality management system, underdeveloped and highly diverse local healthcare systems, and unharmonized, poorly committed, and partly unstable political and economic systems. But these are all improving as we are moving forward. And so the problem and then the aim, improving the attractiveness index of Africa as a destination for global clinical trials and increasing the number of trials conducted, especially as we are talking today in terms of clinical trial in oncology. And our advocation is that each of the 54 African countries should float at least 3 clinical trial units per country, and sponsor companies like it because they are sufficiently enthused with the fact that people are focused on ensuring that the quality of the data is optimal. So that is the ecosystem change we are expecting to influence, the ecosystem change we are, So how can we unlock study participants recruitment in Africa? And we have a solution that recently, is operating in the different teaching hospitals. And we have one second. we have with us right now what is Uburu AI. And the question is, what is the challenge? What is the challenge before us, and what is Uburu AI offering? I'm talking about this because my hospital is one of those that has engaged significantly with the solution that is actually attracting the interest of both research, biomedical researchers who want to do multi-center trials, and industry. So what is the huge pain point? 35% of trials are usually delayed. 25% of trials, they fail. And 33% of trials fail in enrolling up to 5% of patients who are, qualify for the eligibility criteria. And also happens in other research studies that are not clinical trials. So emerging markets like Nigeria, with large diverse population, matured health systems and regulation, have significant potential in diverse study participant engagement and recruitment, and should indeed embrace this solution. So if, for instance, you have a recruitment target, that will give you success, and you find the patients that are eligible, but you may not be able to consent all of them. So Uburu AI leverages trial eligibility criteria data points and queries against multiple it has over 50 million patients on their records, 7 million patients in Nigeria, to identify and contact doctors with eligible patients as study participants. Let me interpret this. What it means is that you want to do a study in, let's say, ovarian cancer. And just as we were asked in one of the collaborative meetings we had, he said, how many ovarian cancer cases can you, can you have available within the framework of your practice? And we said, don't worry, in the next 1 week, we'll give it to you. And we engaged Uburu AI, and it interfaced with our EMR, and it was able to come up with a number of patients we have access to. Not only the patients, but the doctors that are taking care of them and where they are located. So that is a huge advantage and a huge selling point for Nigeria. Hospitals execute a data sharing agreement to onboard onto the system, and Uburu AI will now speak to the multiple hospital databases securely to precisely map where the eligible study participants are currently being kept. And this also has some other clinical management connotations, which is very positive, but I won't go into it because of time. So these are the hospitals that are already onboarding. You can see there is UNTH, UCH, LUTH, LASUT, AKUTH, UDUS, DIFF, NHA, FMC, OWA. So quite a huge number of our hospitals are already engaging, and this is a huge selling point for us to improve our clinical trial attractiveness index. So the next one is that it's registered in the NDPC as a data controller and processor of major importance with NDPC. So it is completely legit. The certificate is there for us to see. And amazingly, they've started interfacing with centers outside of Nigeria. So we'll soon be able to do Africa continent-wide studies. So how can we, this is my last slide as it were, and I'm looking at how can we partner with stakeholders in Africa interested in engaging us in research and interested in engaging us in clinical trials. Stakeholders in Africa can work with African clinical trial consortium to achieve the objectives, which are achieving government policy change in African countries, providing sustainable oversight of clinical trial units by performing the quality management system process and by appointing regional coordinators. The Clinical Research Center in Cape Town is collaborating with us and is the oversight organ because it has had a wide experience of almost about 8 years by now So we're fostering excellence in clinical research and facilitating the research professional development by assisting to obtain training grants. It's also promoting partnerships between relevant stakeholders, e.g., researchers, pharma companies, as I stated earlier, in the continent through networking, offering consultation that will assist African clinical trial units to build ethical capacity and improve their clinical trial readiness and operations, ultimately improving their market value, their attractiveness index to be chosen as clinical trial sites, especially in multi-center trials. So performing evidence-based awareness campaigns amongst African researchers and institutions to accomplish a model to attain quality management systems in African paradigm shift for widespread acceptance of clinical trial systems. So as I finished my presentation, I decided to had access to during the UICC. And I was shocked that everything I have said, I have, proposed, NICRAS has already put it in place as a template and a model, as a rollout. And truly, truly, all we need to do is all hands on deck, working in concert with them, bringing all our energies and expertise together to ensure that all these our dreams, are achieved. For instance, it's looking at building understanding of cancer in our nation, facilitating early diagnosis research, accelerating the translation of research, facilitating health outcomes research and health economics, facilitating technology in cancer research, and developing cancer research leaders. So I heaved a sigh of relief. I said, well, I'm an adjunct professor in NICRAS, so I will be right there, my hands on deck. Even if I wasn't, I would still be hands on deck. So what is our recommendation for the future? Our recommendation for the future is research and innovation should be scaled up, establishing in the past 2 years more collaborations and partnerships with global community to foster research and capacity in image genomics, AI, precision medicine, patient-centered approaches. For instance, we've already started working with some institutions outside of this country, and they are training their AI models with our own images, so that when they come out with solutions, AI solutions, it will apply to our population. So this is so, so important and vital. So I would like to thank you very much as I enjoin you to join us on the 5th of October, Saturday, the 5th of October, to go pink. Just anywhere you are, wherever you are, your organization, just go pink. Don't pink, and send hashtag crush cancer. I will send it for it to be disseminated to all participants, exactly the ways in which you can just do mundane things to big things and go pink. Operation Rid Nigeria of Late Cancer Detection. Every 6 minutes, a Nigerian dies a preventable death from late detection of cancer. We can stop this, but we must act now. 5th October every year, go pink. Join us. Thank you very much.
Wow. Thank you so very much, Ma. This is exhaustive, comprehensive. It has Professor Ifeoma, Emeritus Professor Ifeoma Okoye is she's an Amazon in clinical trials in Africa, and she has dealt decisively with this topic: research, development for cancer control, decisively, emphasizing on oncology clinical trials, volunteers, increasing the volume of oncology clinical trials in Africa. We say thank you very much, Ma. And October 5, of course, we'll go pink with the hashtag Crush Cancer. Thank you so very much. This has touched every corner, every doubt so far. Thank you very much, Ma. We'll be moving on to the third presentation by Engineer Kemisola Bolarinwa. She will be talking to us on the role of private enterprise in cancer care and management. Engineer Kemisola Bolariwa is the Chief Executive Officer, Nestware Technologies, Abuja, Nigeria. Your presentation now.
Good morning. Please, can you confirm if you could hear me?
We can hear you, ma.
All right, thank you so much, Mom. Good morning. Oh, sorry, it's already afternoon. I think we started in the morning, so it's already noon. Good afternoon and happy Independence Day. So I think the previous speakers, my president, my honorable president, and Professor Ifeoma have done justice to everything, because virtually all what I'm about to talk about in that area of the role of private enterprise in cancer treatment and in cancer care and management have been said, virtually everything I've been said. But just to affirm what they've said so far, I won't be displaying any presentation, so I will just go to my affirmation, actually. Please, all right. So please, you permit me to go through, because I'm from a private organization. I'm an engineer in profession, and I'm not a medical practitioner, so I don't need to about medical. But what we are doing is I'm using technology, to solve health challenges. So we are working with medical practitioners to see how we can help use technology to enhance what they are doing in medical field or in healthcare generally. And that will take me through the cancer itself, being a researcher, before we develop a solution, before we develop any technology or any innovation, we need to research about it to know what and why before we determine exact solution that can be tailored to tackle that problem. And talking about cancer, please, I know we are all familiar with heat here. I mean, everybody we have in this call, we are all familiar with it. So just give me the privilege to go through so that you can see where I'm heading to. Currently in Nigeria, cancer cases are tending to increase. The increase is on the high side, to be truthful to ourselves, in all sincerity, the increase of cancer cases is on the high side. In fact, going by the statistics, that we see on many journals, I would say those statistics are only based on the cases that were recorded in the hospital. They are the cases that was recorded in the hospital. Some cases are not recorded in the hospital and they are not part of the statistics. That will let you know how deep cancer is eating Nigeria deeply. And unfortunately, the cases currently in the country, in Nigeria, are detected at the late stages. And I've identified, as a researcher, I've gone into research and I'm able to come up with some problems that is causing this late detection. Like I said, please have it at the back of your mind that I'm coming in as a private enterprise and as a technologist and as a researcher. So during my research, I realized that the late detection is amounted from the lack of awareness, which is number one, lack of awareness. People doesn't know about cancer. The few that knows about it are the people that stays in the city. The people in core Nigeria, the core areas doesn't know, the core Nigerian area doesn't know what cancer is. Secondly, is the affordability of screening exercises. Dr. Ifeoma mentioned about, and I'm sorry, Professor Ifeoma and our president mentioned about some diagnosis centers that have been put in place. You will know that all those diagnosis centers are only in the cities, major cities. And the cost of accessing this services are on the high side, which an average Nigerian cannot afford. With the affordability makes it the third problem that we are having that has amounted to the late detection. And this has been the problem that have, contributed to the late detection, because majority of the cases that we have, comes in at the late stage. They get into the hospital. Majority of the people that reach out to me, since I've I've gone into the cancer advocacy. People come, reach out to me. Oh, I have someone that is going through cancer, is dying of cancer. Can you help with funding and all of that? When you go in and ask questions, you will realize that they come in at the list stage 3, stage 4. Even myself, what led me into the advocacy is as a result of my auntie that lost her life to stage 4. So most of this problem comes in at the late stages. And the problems that amounted to this are what I've highlighted based on my own research as a private entity and as a researcher. So this is why we can't just leave it for the government or international organization or some healthcare NGOs alone. I think it is high time that private private entity comes into this cancer care, cancer management, and even cancer awareness. Perhaps call it maybe cancer advocacy. So I've highlighted some areas where we need them, which our speakers have already mentioned. The number one thing is the cancer awareness. The awareness, it is very important. I realized that the first key in the fight against cancer is awareness. You can't be ignorant of something that you don't know about. It's not possible. So that is why we need, as a private enterprise, to go into the awareness. In fact, it's not just private enterprise, it's a call for everybody. Like I said, the fight against cancer, it's the role of individual, not just private or international or government organizations alone. It's a role, it's the role of everybody to sensitize your neighbor, to sensitize the person next to you, to let them know, because these people doesn't know what cancer is. We still have the misinterpretation of cancer to the religious belief. As you know that we are in a religious country. So we still have the misinterpretation of this. So we still take cancer to our religious belief, so to speak. We say it's my village people. There's something that happened last week in my mother's area where she owns a shop. Some advocate came in to sensitize women about breast cancer and also to do some free screening for them. So they had to call those women together. Oh, come, we want to do this for you. They were just coming and leave. They will come. And what are they doing there? Cancer? No, I don't know about it. They will go. It's all my mom that was telling me this. She now said that she had to call them, come. Fine, you don't know about cancer. Don't worry. I will tell you what the thing is. She now mentioned 3 women that she knows that they also know that have died of this. So you don't know it was cancer. Okay, now that it is cancer that killed them. So that is why you need this sensitization, and you need this, screening service. The free service that was brought to you is an advantage for you to have this free screening. And these women, according to her, they gave her the listening here because she was able to give them instances to open their minds to it. And they went back to where the advocates were and they sat down and listened to what they were saying. This is where we all need ourselves to call on ourselves to do more in this advocacy, in awareness creation. We are already in city. We already know what cancer is. Like I said, majority doesn't know, and that is the truth. And most of the advocacy, I have to be sincere here. We have so many foundations, so many, advocates. The
Hello?
people at the grassroots. Hello, are you there?
We can hear you now, ma.
All right, thank you so much. I was saying that the advocacy that we have on ground, we have so many foundations, and it's quite impressive that we have some foundation, we have some people now dedicating their time into cancer advocacy, into cancer awareness raising. But the problem is we are not really doing it to the best of it to make a meaningful impact. Because most of this advocacy, most of the sensitization that we're doing are only done in big cities. We do them in Lagos, we do them in Abuja, we find ourselves in Port Harcourt, in the big cities. That is where this information has been passed across. This information are not getting to the grassroots. They are not getting to the people that needs to hear it, that doesn't even know what cancer is, that cannot even differentiate between cancer and the traditional whatever, the village people have attacked me. Yeah, spiritual harrow, so to speak. We are not doing enough. Both private, both public, both international. I know the international are doing the disseminate the information through the NGO, the CSOs, but we are not getting to the grassroots. We need to do more concerning that, to let these people know that this is cancer. You don't need to mix it together. When you say something, you run to the hospital for proper screening. And that is why I said it is very important that private enterprise and everyone, or not just private enterprise, every one of us take it as a duty to communicate this information to our people, especially the people in underserved communities that doesn't have access to internet, that doesn't have access to this information. And for our CSOs, our advocates, our NGOs, please try and take this information to the grassroots, not dancing around Abuja, not dancing around Lagos, don't dance around the city of Port Harcourt. Let's take it to the people that needs to know. We already know. People that listen Abuja, people that listen Lagos already knows about cancer. They knows. The people that need to know about it are the people at the grassroots. So I want us to do better around that area. So the second point where I think private enterprise could come in the care of cancer and management is research and development. And I was so happy that the way Professor Ifeoma did justice to that. She really did it justice to that. Research and research area is just very, very important in the fight against cancer. But as a country, or I would say as a continent, as African continent, we are yet to realize that, because the Western nations are far, far, far ahead of us when it comes to research. The truth is, you cannot come up with a solution to a problem that you don't even have an in-depth of. You can. And how could you have an in-depth of the problem? It's for you to go into research. You research about it and see the possible solution that can put in place for it to solve the problem. But we are doing little to that. Even our governments are not helping. Thank God, I'm so happy. I'm so happy about the new setup of the NICRATs. And we hope to see better on their mandates, the implementation of their mandates. We need to do more. Find there's little to what private enterprise could do, because research requires funding. That's just the sincerity about it. It requires land funding. And it's not something private enterprise can absorb alone. They need the support of the government in this. But we are not getting it. The private enterprise are not getting it. And the private enterprise are not even looking in that direction of research. We are still dependent on the Western solution. Prof said something about data analysis. You want to feed your data, you want to feed your AI for a solution that will be utilized in Nigeria, and you're using white people's data or you're using foreigners' data. How would it work? For a solution that will be done in Nigeria, that will be implemented in Nigeria. So it has to be a data that is fetched by the people that the solution will be impacting. So private enterprise have to look into that area of research. Do more of it. I know I've said it's capital intensive. That's the truth. But we need to make that move. There's so many grants out there. There's so many support out there from the international organization. If our government is not even helping, we can approach those people, the private organization that knows the value. Because the truth is, cancer, it's a global problem. It's a global threat. It's not for Nigeria. It's a global threat. And we have those international organizations that are there to invest in research and see how the solution, whatever solution you're bringing, could impact your own community and impact the world at large. And it's also a call for the government to invest more in research. Our governments are not doing well. And I believe those webinar, the report will be put together. I'm very sure of that. Put together and being shared with the stakeholders in this, in this ecosystem, cancer ecosystem, which include the government, because it can be just closed door meetings, having webinars, talk, and no positive impact of whatever, hours of meeting that we'll be doing. We want to see results. And how can we see results is for us, after this deliberation, whatever we've done, we give the report to them as a stakeholder. This is what we deliberated on. And I'm sure they will see how they will implement our deliberation. And that is why I'm calling on government to invest more in research, both on the innovation, both on the technology, both on the medical, We need that innovation. We need investment in research. It's we that are Black, it's we that are Nigerians that can solve a problem. White man cannot solve a problem. We can only solve a problem. That is number 2 point, where I think private enterprise could, partner to do more in cancer care and management. The third one is innovation. And that is where I personally comes in. Like I said, I'm a researcher. And based on my experience, I came up with, I went under that research to see, women are dying. Women are dying of breast cancer in Nigeria. The survival rate, like Prof said, in the Western world is higher than what we are recording here. Their survival rate is on the high side. They're surviving it. But here, more women are losing their life to breast cancer. Probably being a woman, that was why I choose that interest in breast cancer. Let's tackle this first before I go into other cancer types. And during the research, I realized that, like I've stated earlier, late detection is a problem. And this problem is caused by lack of awareness, or this problem is caused by inaccessibility of the traditional screening method. And even the ones that are accessible, how many people that can afford it? Because average Nigerian live below $5 daily. How could they afford a mammography that is done for 40,000 naira? So I went into research and I came up with an innovation that could tackle that problem, that could make, screening, quick screening, accessible to everybody, irrespective of the background or financial status. And that is where private enterprise comes in cancer care, in researching and coming up with innovative solutions that can solve the problem that we researched on. We need more people, we need more private enterprise to do more in innovative sector, section of cancer care and management. We have so many, mine is about, hardware, bringing hardware and software together, including AI. There's so many ways that we can innovate this. Like Prof said, AI, bringing in AI, it makes the work easier. MRI recently, the truth is, an average medical practitioner find it difficult to even, interpret MRI in a day. Some will tell you, come back the following day to do it. Now we have, innovation. It has been innovated into AI, where you have your results. You just scan the result on your AI, and it interprets the image, the result to you, the MRI result to you. That is the power of innovation. And we need to do more in that area. I know it requires a whole lot of funding and time, but I think if we make that step, like I said, we will get there. There's so much funding out there for us to be able to assess and create a meaningful impact in area of innovation. The fourth one is technology. It's no news that technology is already revolving the whole world. You see what is happening. Thank God for the era of internet. The internet made us to see, the internet have bridged that gap that has always been there between us and the Western world. So we can see clearly what the Western world are doing. We can see clearly how far they've gone. So we are seeing this every day on the internet, seeing robots performing operations, seeing AI performing things, making our work easier. Everywhere now, it's all about AI, robotics going on here and then, nanotechnology and all of that. We need technology. We need to accept technology. And this takes me back to the issue I had then when we started that project. We needed some data sets to feed our AI. And I approached the National Hospital, Abuja. And I don't know, probably is a radiologist. I met him there and I told him about what I'm doing. Please, sir, I need some data sets. And the first thing he's going to tell me is, I think your solution is going to be a threat on us. And I said, no, sir. You don't need to see technology as a threat on your traditional way you perform your duties. No. Technology have come to aid what you're doing, to assist what you're doing, not to replace you. Likewise, what we did, our solution, which is a smart Baracom diagnosing device, have come to aid what you're doing. Is not to take the job of a radiologist. Whenever you use a device and there's something detected, it will still take you back, refer you back to the hospital for proper diagnosis. We are not taking your job. We are only aiding what you're doing. But currently now in Africa, we still see technology as a threat. We see them as a threat in our daily jobs, not just medical line alone now. In businesses, some still, I mean, even in workforces, in government. We still have some government, we still have some offices that still do all with paperwork because they see technology as a threat. No, we still need to do, relent on the former way of doing it. No, we can't bring in computers not to take a job. No, technologies have come in, it has come to enhance our work for efficiency. So we need to do more, to go more as a private enterprise in invest more in technology. Let's see how we can bring in technology to aid cancer care. Let's see how we can use technology to aid cancer management. Recently, I bumped on a lady and a Black American lady that is a physicist actually, and she researched on the technology for cancer treatments using satellite technology, using laser particles and nanotechnology. This is what we're saying. I don't know, maybe it has been approved by FDA, but she did it. She has gone into clinical trials and it works. Another one is MiniBot. There's MiniBot now, is a robot, miniature robot that is built for cancer treatments to kill the cancer cells. It will go into the body and look for the cancer cell, the dangerous cancer cells, look for them and kill them. That is what technology has come to do, not to take us away from our job. Fine, it can take you away from your job. That's just the truth. If you did not upskill yourself, there's a need for us to get ourselves upskilled. Be it you being a doctor, a medical practitioner, whatever profession you find yourself in, medical or in healthcare, you need to update yourself, upskill yourself, acquire more technical skill, technology skill that can aid what you're doing. Because if you're not skilled enough, with the era that we are going, because either we like it or not, technology has come to stay. Technology will be used in healthcare. And for you to be able to hold your job, to still perform your duty, you need to know how to use technology. So this is another call for us as an healthcare practitioner to look for an area of technology that you can acquire to aid your job. But if you don't, the era is coming. It's not a threat. It's a reality. It's coming that some job will be lost due to the fact that you don't have some skill set, to fit into that role anymore. And that is why I said that private enterprise needs technology, needs to go into technology. So you see how they use technology in the area of cancer care and management. And lastly, just a minute. I've mentioned awareness creation, investing in research and development, and collaboration with public health and institutions, especially in the area of treatment. The truth is, cancer treatment is not meant for the weak. And that is why we see some of our people, some of the cancer patients, they later lose their life to cancer because of they don't have the capacity, monetary capacity now, finance to treat it. It's obvious. The truth is, it's expensive. Cancer treatment is expensive, and I'm so happy with the new step that the government took, initiating this cancer treatment fund to support cancer patients, which is an initiative that I think that when I heard about it, I was blown away, like, oh my God, so our government could do this. And I could see some people, testimony of people that, access the funding. Now, lately, I'm talking about not the previous one, because it has been under some people previously, which are not accessible by people. You are not accessible by the patients. But I'm so happy that has been taken away from them, given to another another entity, to anchor. So people are not having access to the funding. This is a win for us as a Nigeria, and it's a win for everybody. It's a win for the government. It's a win for everybody as a Nigeria, because cancer treatment is not a child play, which needs support. So as a private entity, I think there's more we can do in that area, in subsidizing. If there's anything we can do, initiative that we can put on, to help cancer patients, in partnership with healthcare institutions, like the main one that we have, for example, national hospitals where they treat cancer patients, partner with them, see how we can, raise some funding for them, put it in that hospital. When you have cancer patients, you can take out of it to treat them. So these are the areas that I think we as a private enterprise could do more. And I would say in conclusion, well, like I said, the major fight in cancer, the major key, the major key in the fight of cancer is awareness. I cannot be an ignorant of what I don't know about. And for our CSOs, for our advocates, for our NGOs out there, both government, private, NGO, whatever NGO, please, let's take this information to the grassroots. We've done enough for the cities. We need to go into the core Nigerian part, the part of Nigeria, the core places, to take this outreach there, to take this information to them, let them know about what cancer is. And I'm sure we are going to win this fight, because it's a fight, it's quite a fight. We are in the fight with cancer. And if we can be able to put all this in place, we will win this fight, we'll win the battle against cancer. And thank you so much for the organization, for the organizers of this webinar. Thank you. Thanks to our audience and to our NGOs, our CSOs. Your work, I can say that your work is really impacting. At least, though it's a slow and steady thing, but we need to do more. It's really working, but we need to do more in that area, to make sure that everybody knows about cancer and to sensitize them and to educate them about it. Thank you so much, and God bless us all.
Thank you so very much, Ma. Engineer Kemisola Bolarinwa, she is the CEO, Nestware Technologies, and notable in her contribution to this invention of Grand she was able to invent a smart bra cup diagnostic device that has the capacity to detect the earliest stages of breast cancer. This is unprecedented, and it has earned global recognition awards. And thank you for your very powerful speech. And not the cities. We should where the cancer is eating deep in our communities, and not just Abuja, Lagos, and all of sorts. So in the next 25 minutes, we'll be having discussion. We've had rounds of presentations. Dr. Adamu Al-Hassan Humer, the President CEO, Nigerian Cancer Society, talks extensively on the role of NGO, civil society organization in advocacy for cancer. Emeritus Professor Ifeoma Okoye came in with some armamentarium of clinical trials, oncology clinical trials in cancer research and development for cancer control in Nigeria. And the presentation was wrapped up by the role of private enterprise in cancer care management by Engineer Kemisola Bolarinwa. We've listened to all this, and the floor is now open for discussion. Implore everyone on call. Let's put our hearts together. How do we improve cancer outcomes? Improve cancer outcome in Nigeria. Thank you. Welcome for discussion, questions, suggestions, contributions, clearing all doubts, way forward.
Hello.
Yes, sir.
Good afternoon. Is it okay in the afternoon? Then,
yes, it's afternoon, sir.
My name is Abdulkadir Shafa Alabelewe, the Technical Lead for Inclusive Women and Youth Initiative, which I really appreciate the presenters, and also to be on. To be on record, also I have a very close relative that is currently battling with breast cancer, and which is not been easy with the cost implication and the rest of them. But what I will now say that like some of the speakers says, there's need for intense advocacy to government and also the private. Like for instance, now the local government have some little, they have their direct funding from the federal government. If there's more advocacy can be targeted to them, so at least to see how they can have some little funding for awareness at the local government level. Because I just imagine me, my close relative that is having breast cancer now. Let's imagine the person is in the village, then it will be a different ball game. And there are a lot of patients in the villages, remote areas that are suffering from that breast cancer. But trying to see how the local government chairman can realize the need for awareness on that will also go a long way. Thank you very much.
Thank you very much, sir. How will the people in the local government benefit? I was talking about indigent funds. How do the people in local communities benefit from cancer prevention, cancer treatment? Professor Okoyema. Hello?
I'm trying to
I can
unmute.
put one hand up.
Thank you. Thank you so much. I was trying to, because I snapped the name of the last speaker that spoke on behalf of the private sector. She made a lot of amazing points, and our last speaker as well, who asked the question. So there are quite a lot of efforts that are on ground being made to reach the underserved areas of the country. I tell you of one structure that my organization, Breast Without Spot, which is championing this nationwide grouping day. The whole essence of it, up to 70% of our population actually participate in social media. So that's why one of my AKAs is Pinky Prof. Because in 2015, I actually initiated initiative because there is so much fear. And remember, one of the things I said is that we need to debug our tumors. We need to downsize the stage, which is what you spoke about. And it's by downsizing those hospitals to receive care that people with lived experience that can share their story. Right now, the current narrative is of late detection. Even the WHO said that if you are asked the 3 reasons for low and middle income countries why there is increasing mortality and morbidity statistics in cancer, they will tell you it's late detection number 1, late detection number 2, late detection number 3. So there is a need to mobilize effort. Every effort we are doing, in terms of treatment, management, diagnosis, and all that is important. But there is a reason to look down and ask yourself, who is throwing all those people in the swimming pool that you're trying to save their lives? You're diving to bring them out of the swimming. Who is throwing them down? It has to do with prevention. It has to do with knowledge. So you need to pass knowledge about prevention. You need to pass knowledge about the need to lose the fears, what we call screening hesitancy. There is screening hesitancy. Everybody's caution syndrome. All these are documented in research. So what are we doing? We've been raising an army of advocates through the National Youth Corps Service. We have a BWS, which is my NGO, Breast Without Spot, CDS in the NYSC since 2009. But the problem we have is funding constraint to do what we need to do, to mobilize as much as to be able to reach the 774 local governments. This is an existing infrastructure. Is there 247? Is there TDS? So we can utilize them to disseminate this information in the 774 local government and raise significant awareness. So this is very, very important. That is a structure. Another structure is one somebody mentioned, the local government chairman. They can also assist through the ward people to get into the 774 and disseminate into the wards. There's also a structure in the primary health care that is called the chiefs. They intervene with the family units at the level of so if we've been leading advocacy to have included in the primary health care package this awareness and a lot of information on cancer prevention, and even to train people right there in the local government structure to know how to do the basic screening that needs to be done, both for breast, for cervical, for prostate. So these things are possible. It's just all hands on deck. It's also, assisting the government to fund some of these initiatives, to fund the NGO philanthropists that can put their hands on the plan. Corporate organizations, individuals, that everybody can come and help to fund. Just on this Saturday, my who was financially buoyant, instead, if you enable us, we'll and screen them for breast and for prostate early detection of the Cancer Health Fund. We can't to the tertiary care hospitals that are operating the Cancer Health Fund. And
the signal.
Our president also talked about the health insurance provision for cancer, and there's a lot of provisions. So let me stop there. Effort going on in the local government, but we know a lot of NGOs. They focus, on underserved areas, not only in the NGO. We worked literally today. We even have a women health army that we screen them in the urban area, and then we use them as gatekeepers to their own communities. So these are some of the structures. There are so many structures in place, but we need to have more engagement with those who can facilitate and fund and help us to have access to the population. Thank you so much.
Thank you so very much, Ma, for your response. We can see that a lot of work has been is on ground, and structures and even more structures are emerging in control of cancer in our communities, especially from even the work Professor has done, reaching out to the 774 local governments across the nation. Thank you so much, Ma, for your response. Mr. Leonard Alika. Sorry, sir.
Okay, good afternoon.
Good afternoon, sir.
Thank you for the presentation, the awareness going on. I think it's a welcome development. I thank the speakers for their impact in this webinar today. I have a little concern with respect to attitude of Nigerians or patients per se when it comes to radiation exposure or prevention of cancers. and the practices we do. Especially, the question goes to Prof. If she's listening. I've had an instances, occasions where people come in, you see some persons, they have not seen any doctor, they have headache, they run to go and do a CT scan. They have pain, breast pain, they've not seen any doctor, they are going to do mammogram. A particular case was worrisome. A man, the daughter was, I think she was about 20 years, the child was 20 years, had a complaint of breast pain. He went to do mammogram. No person referred him, no doctor referred him. Just about a week after, the child was complaining of headache, dizziness, fainting spells. The man went to a lab and did CT scan. And I was asking him, did you see any doctor? No, he just did it on your own. What are you looking out for? So my question to the Prof, I know we are talking about ways to ensure there is awareness and prevention of cancers. And radiation exposure, unnecessary radiation exposure is one of the ways through which people can accumulate their risk over time. This child is is about 20 years, starting to do CT scan unreferred. What happens when that child turns to 40, 30 something years? The person will see it as a way of life. Any little thing I want to do is I want to do MRI, increasing the exposure to radiation. What is the radiology units, the society, what are they doing with respect to counseling patients on the need to do the right thing, not just rushing into any lab that have the facility to do these investigations and do them? How are we going to encourage or educate the people to know the right things, the right steps to do to protect themselves from exposure to radiation and preventive practices to reduce their chances of having cancer later in life? Thank you so much.
Thank you very much, sir. Question to Prof. Ma. And how
Okay.
regulating radiation exposure, ma.
Okay. So this is really very deep and very painful. Those encounters of these young ones. First of all, we have the Breast Imaging Society of Nigeria. Very, very active. You see, the problem is that, like, when I started breastfeeding, I was so enthusiastic. I ran to the media, go this and that. They would tell me, we are commercialized. This world, there are so many problems. Cancer is not the only problem. If we give free media, that was when we were using electronic and print media. But now, thank God for social media. That is what is saving us, because, you need to pay for any information. In one of the main primary slides I put is that Nigerians are denied of health information. One of the International President of Medical Women, one of her major papers was on that. Denial of Nigerians of health information. It needs to be mundanely available. It needs to be, like sand. But that is not the case. So even as the radiologists have been screaming about this rascality of centers setting up, and then people doing wrong practice because the workforce is not the right workforce. This must not happen. A child of 20 years, what is the mammo? The mammo is going to come out near because the breast is still dense. No lesion will show. You can't do mammography in breasts less than 40 years. There are other ways you can use ultrasound. You can do, there's some other screening tools. You can use MRI to screen the breast. But it has to be examined by a doctor. There needs to be a referral system. And just as I said, most of the constraints we are suffering is inadequate funding and assistance to enable those that are in the field to carry their message to the people. I call it take the message to the people and take the service to the people. And we can do that effectively through mobile service as well. So these are very important. The oversight is there. There are the registration bodies that are there to do the oversight. But of course, we know that we have rules and regulations, we have constitutions and everything, but oversight is very, very difficult
Deficient.
in the country. So you need to improve on the awareness. If you know, the important thing is that the people need to have informed consent. They need to have informed choice. The only way they can have an informed choice of what they should and should not do is by giving them the information and making sure that that information is given to them. If you go out of into high-income countries, you will see information about health mundanely available. We were in a program last week in Abuja, and one of the participants from Uganda was telling us how when you come to the gate, there is a track with different colors that tells you exactly where to go. And from the gate, they will tell you, follow purple track, follow green track, follow yellow track, so that you're not perambulating up and down to the patient that is already weak and inundated from the disease entity. So we have Breast Imaging Society of Nigeria. We have even in UNTH, we have a protocol both for screening, diagnosis, and management for breast cancer. We also have developed the same for Breast Imaging Society of Nigeria. I was the chairman of that development of that protocol. And it's published. But how do we disseminate so that it will get to the people? And they are custodians of this information. Indeed, one of the things we do with this Go Pink Day is that we use the opportunity of trivializing the issue. And as people get engaged, you now win. In fact, one of the things I got as a secret assignment is that this disease has decided to metastasize itself. And it is important to metastasize information about it. Thank you very much.
Thank you so very much, Ma, for
And
your response.
I will actually, guys, of radiologists in Nigeria, and I'll bring this issue to them so that we can, engage more and see how we can disseminate more information in this direction.
Thank you so very much, Ma, for your response. Health information has to be well disseminated. There's a question in the chat box for Engineer Kemisola. Someone is asking, I would like to know how far you have gone with the breast cancer detecting device that you developed. Where and how can this be obtained if one would want to get them across to our women? Which age group can one target with this technology?
All right, thank you. The device is actually for based on the trial that we've conducted so far. We are yet to go into the standard clinical trial. We just partner with Medicaid for our clinical trial, which will be conducted very soon. So for now, we've used the device on women between the age of 20 to 60. So both those ages between that range can use our devices. And the device is built in such a way that it will be available at the grassroots. So in essence, we are going to be partnering with health practitioners, clinics, NGO, female women NGOs, and local pharmacists, local pharmaceutical stores, where this device will be deployed. You as a woman, you can just walk into those facilities and get yourself screened. It doesn't require some technical knowledge to be able to use. So we design in such a way that you be able to afford it. If you cannot own one to yourself, because by the time it's going to be out, it's ultrasound technology is going to be a bit expensive. It's just like the probe that you have, but not as expensive as a probe. But at the same time, it's going to cost about maybe $450 to $500. So that was why we're going to do it in such a way that we have it in every health facilities, local health facilities, for easy accessibility for people to walk in and utilize the device. So what we use is ultrasound. Yeah.
Thank you very much, Matt. Sorry, we are running short of time, and in the next 15-20 minutes, we should be wrapping up. The goodwill message will be coming forth from Dr. Chimaroke Udechi, the CEO of Mobile Lab Nigeria Limited. Sir, the floor is yours, sir.
Okay. I want to thank everyone for this opportunity to be here, and it's been very rich and enlightening the session we've had so far. I thank Professor Ifeoma Okoye for her elaborate and beautiful presentation, and the engineer as well as Dr. Hassan, my very good friend in the house. Professor Ifeoma Okoye has been on the case of cancer for, I don't know, 20, 30 years. We actually started Breast Without Spot together, and she had so much energy and passion, and that energy and passion is still burning in her. I want to thank her so much for what she's done so far. I want to be made a host so that I can share my screen. I don't know, can I be allowed to do that? Okay, that's fine. Okay, so in the next few minutes, I just want to, I know we've all been exhausted and a lot has been said today. I don't want to take too much of our time. I will just be brief in my presentation. And my presentation is something, I don't know if you can see my slide. Can you all see my slide? Hello, please, can you see my slide?
No.
Okay, 1 minute, 1 minute. Is it visible now?
Not yet.
Not yet. Okay, let me try to share again. If it doesn't share, then I'll just talk. Is it showing?
Yes, please. Thank you, sir.
All right. Okay, so I'm not going to show all of the slides here. I'll just take the key points. So we represent Mobilab as Mobilab Medical Innovatives, and it's a US company. It's in biotech space. And what we'll be talking about today briefly is about the detection of oncoproteins E6, E7, which is a rapid test kit for oncogenic HPV screening for prevention of cervical cancer in low resource settings. We've been talking about information, awareness, affordability, professionalism, and a whole lot of things. And one of the keys to cervical cancer, breast cancer, most of the cancers, prostate cancer, is early detection. That's the only way we can prevent early or reduce the late detection and associated morbidities and mortalities. So Mobilab introduced not too long ago, about a year ago, the oncoprotein rapid test kits. So what that means is that simply you can actually detect cervical cancer risks, in a few minutes in the clinic, in the ward, and in the space out there, maybe doing a medical, maybe in the outreach, medical outreach. So you can just use this kit to do that. By way of introduction, our company does a lot of these rapid test kits, the biotech company, and we've had so many kits, but for now, we'll just focus on cervical cancer. So according to statistics, NMR states that 13 new women are diagnosed every day and 22 die. I'm sure with implementation of the cancer registry policies, Professor Okoye, Emeritus Professor Okoye talked about, we'll get more accurate data about all of these things that are happening. But we all know that the risk of cancer in low and middle income countries like ours is due to, one, lack of national HPV vaccination until last year, lack of mass high performance testing for HPV. And in that document, Dr. Omar Hassan mentioned, the cancer control plan for the country, high performance testing comes in very, very importantly there, because people have to be tested with methods that will give them that will give accurate results to the healthcare professionals, late presentation, unaffordable treatment, and so forth. So I don't want to bore us with facts about cervical cancer. This is available anywhere. But the risk factors for cervical cancer, number one, is the strain of the virus. The cancer in high risk strains, which are 16, 18, 31, and so forth. But 16 and 18 are responsible for 70% of them. And the immune status of a woman is very, very key, because to a large extent, our immunity can take care of it. As a matter of fact, 80% of all HPV infections, are taken care of by immunity. But when there's a presence of other sexually transmitted infections, that reduces the immunity, and the likelihood of being progressed into a cancer is there. Number of births, age at first pregnancy, use of contraceptives, and smoking are all risk factors.
We appreciate
But,
if you are a little faster, sir, because we are running very short of time, sir.
Yeah. Okay. Thank you. So these are just the common methods for the screening. But I'll just say something about national control, cancer control plan in the country. In 2020, WHO set a goal for elimination of cervical cancer by 2030, and the key was 90-70-90, which is vaccinating 90% of girls, screen 70% of women, and treat 90% of cervical diseases. And the key was screen and treat. And National Consensus Program of Federal Ministry of Health for Girls 1914 was introduced. But the next thing is the screening. We need to be screening 70% of women, but we'll have no screening, all of that. But what we've done in our company is to take care of certain problems like low affordability, little funding, limited professionals, loss to follow-up, and loved ones restrictions. Low affordability means most people can't afford screening, but we have developed a kit that is very, very cheap to afford, and it's quite affordable, and it comes out in 10 minutes, and it detects oncoproteins E6, E7. Now, these oncoproteins E6, E7 are responsible for the mutation of cervical cells from normal cells to precancer and cancer. And if you can detect it in a kit, it means the woman has a very high risk of having the cancer. So in conclusion, the 16, 18, 31, 33, 45, 52, 50 are the ones it detects, and the specificity is quite high. We thank you very much for your listening. And then if you like to know more, just click on the link I posted in the chat and then share us your feedback. Thank you very much for the organizers of this event. We appreciate
Thank you
so
so very much,
wonderful.
sir. Thank you very much, sir, Dr. Odechi. Thank you so very much. So we'll be rounding up now. We want to recognize the presence of the Medical Women Association of Nigeria, Kaduna President-elect, Dr. Zainab Kwaru. Thank you very much, ma'am, for being on call. And the vote of thanks will be delivered by Miss Madam Ifenyinwa Okeke, National Outreach Committee Chairman, Kaduna. Your floor, ma'am.
All right, good afternoon, everybody. All protocols observed. My name is actually Dr. Ifeanyi Okeke. I am the Medical Women's Association of Nigeria, National Outreach Committee Chair. It's a privilege to be here, and thank you for calling on me to give this vote of thanks. I want to really appreciate the organizers of this webinar, the Cancer Health Initiative, ably led by Dr. Tafik. Thank you for finding time to organize this webinar, the 8th special commemorative online sensitization webinar titled Nigeria at 64, Path to Improving Cancer Outcomes. A big appreciation also goes to all the partners, Cancer Consciousness Initiative, Nigeria Cancer Society, UNN Center for Clinical Trials, M1 Kaduna, and others that I may not have mentioned. And our dear speakers, thank you so much, Emeritus Professor Ifeoma Okeye. Thank you, my great and big medical woman. Thank you so much. Also want to appreciate the President, CEO of Nigerian Cancer Society, Dr. Adamu Al-Hassan Umar. Thank you, sir. Indeed, NGOs have a big role to play, and they are doing so. And Engineer Kemi Bolarinwa, the CEO of Nextware Technologies. Thank you so much. And Dr. Chinwoke Udechi, we appreciate you so, and everyone else that is here. Oh, M1 Kaduna, I can't forget that you're also a partner here. Thank you so much. Everyone here, we appreciate you. It's actually hours plus of listening about the best ways to improve the outcome of cancer. Thank you so much. Over and out. Good afternoon, everyone.
Thank you so very much, ma'am, Ms. Dr. Ifeanyi Okeke, for the vote of thanks, the closing remarks. We really appreciate everyone that has been on this call. It's been very educative, and it's a take-home message to fight cancer even at the grassroots, and that nothing is impossible at the level we are in Nigeria, in spite of all these challenges that is surmounting the country. So Nigeria at 64, path to improving cancer outcome. Thank you, everyone. Thank you, speakers. Thank you, Professor Okoye. Thank you for the presentation. Thank you very much, ma'am.
Thank you, our dear facilitators, too. You did a great job. Dr. Temilade Aderono, also a medical woman.
Thank you so much, ma'am.
Love of a mother. Thank you.
I appreciate you, ma'am. Thank you, ma'am. Yes, ma'am.